And I will use that later on to move around. Yeah. Right. We're going to do the 3, 2, 1, go. Oh, it's a bit low. Hello, good evening, everyone. Thank you so much for being here in person for another Knowledge Exchange. My name is Annemieke Verenhorst, and I'm the Associate Vice President Research at the University of Manitoba. So let me begin that the University of Manitoba campuses are located on the original land of the Anishinaabe, Cree, Ojibwe Cree, Dakota, Dene peoples, and on the homeland of the Red River Métis Nation. As a member of the University of Manitoba, I'm extremely proud to be part of research partnerships in collaboration with Indigenous peoples in a spirit of reconciliation. I would also like to thank the many people that are joining us online. Thank you so very much for your attendance. It's good to be back in the Greece with the friendly staff. The kitchen is open during the event, so if you would like to get something from the menu, feel free. We also have some free coffee, teas, and cookies right there on the bar, so feel free to get up and take some. And as you know, the Knowledge Exchange is an important opportunity for researchers to share the latest information with the general public and the community at large. And the Knowledge Exchange is a partnership between the Office of the Vice President Research and International and the Learning for Life Network. So today's event is entitled Heart, Health, and You. And we will learn about the factors that are contributing to women's heart health and have conversations about treatments for heart disease. And this topic is actually very dear to my heart, and no pun intended, but my mom actually was diagnosed with a congestive heart failure not that long ago. And fortunately, thanks to an excellent team at the hospital, she's doing well and she is in recovery. So thank you so much for all the hospital staff that is there for the patients. So chairing this evening is Dr. Lorrie Kirshenbaum, who is very well known, and he actually received the Order of Manitoba in 2023, and he has this beautiful proof on his vest there, and that is because of his long-term career achievements and also for his enormous mentorship in trying to follow in your footsteps the next generation of scientists. So Lorrie's research program focuses on uncovering the genetic roots of heart disease. Lorrie holds a Canada Research Chair in Molecular Cardiology, and he is a professor in the Max Rady College of Medicine. If that's not enough, Lorrie is also the director of the Institute of Cardiovascular Sciences at the St. Boniface Hospital. So thank you so much, Lorrie, for everything you do. And with that, it's my pleasure to pass on things to you. Thank you so much.
Thank you very much. Thank you very much, Annemieke. I'm delighted to be here, and thank you for joining us in person and, of course, online. So, as Annemieke had mentioned, that the focus of this evening's event is to talk about heart disease in general, but predominantly heart disease in women. And I'm thrilled to be here today with our wonderful panel that you'll meet later on this evening, Dr. Ina Rabinovich-Nikitin, Dr. Shangbo Liu, and Dr. Brad Doble. And each one of these individuals are linked because they have an interest in saving lives through research and patient care. So one of the things I would like to ask and for you to consider is, did you know that heart disease is the #1 cause of death in women in Canada? It even exceeds all types of cancers combined. Furthermore, women do not even know that they have heart disease, which affects basically 1 in 3 women worldwide. So let me put this into perspective. I'd like you to think about the women in your lives. Think about 10 women, your mothers, sisters, daughters, and friends. 3 of them will have or already have some form of heart disease. So next to the reproductive system, the heart is the second most different organ system in the body between males and females. Yet women are still understudied, underrepresented in various clinical trials, and their cardiac symptoms either go unrecognized or undiagnosed. Simply put, traditional heart research has been failing women. Closing this knowledge gap is one way to ensure better outcomes for women with heart disease. Unfortunately, Manitoba is one of the few provinces in Western Canada that does not have a dedicated women's heart health research program. But hope is on the way. The Institute of Cardiovascular Sciences at St. Boniface Hospital has taken the lead role and is committed to establishing a dedicated women's heart health research program here in our province. By growing knowledge through research, we can increase awareness, improve diagnosis, and empower women and their doctors to better recognize symptoms of heart disease. Phase 1 of this initiative is to increase capacity through recruitment and by adding new scientists that will study women's heart health and women's heart disease to be part of our team. This program will be the first of its kind in the province and will have a significant impact on the women in Manitoba, Canada, and worldwide. Research improves odds, speeds up recovery, and ultimately saves lives. So let's close this knowledge gap in women's heart health for our mothers, our sisters, daughters, and our friends. So as you'll see today and this evening, heart disease affects women of all ages. It affects men, it affects children. And what's very important is to establish a team of investigators that can translate our work into improved patient care. So tonight, you're going to hear from these wonderful experts who are going to provide information about the research that's ongoing and the clinical care. But I would like to point out that any information provided in these presentations should not be considered medical advice and is not intended as a substitute for medical professional help, advice, diagnosis, or treatment. Always seek the advice of your physician or any other qualified healthcare provider if you have any questions regarding your medical needs. Okay, so that said, I would like to bring on our first speaker, and our first presenter is Dr. Ina Rabinovich-Nikitin. She's an assistant professor in the Department of Physiology and Pathophysiology at the Max Rady Faculty of Health Sciences at the University of Manitoba and holds the Evelyn Wurzakowski Family Professor in Cardiovascular Sciences at the Institute of Cardiovascular Sciences at St. Boniface Albertson Research Center. So, Dr. Rabinovich.
Good evening, everyone, and thank you very much for being here today. So, as you just heard, heart disease is on the rise for women and also is the #1 killer for women worldwide. And why is it? Why heart disease is on the rise for women? So one of the main reasons for that is that women are understudied. And in fact, in the early 70s, NIH and FDA released an instruction to exclude women from clinical trials. And why is it? So for 2 main reasons. First of all, for precautionary reasons, because women can be pregnant and not know about it, and we know how different treatments can be toxic for the babies, especially treatments that are still being tested, but also because women have hormonal fluctuations throughout the months. And these hormonal fluctuations can basically affect the results of different studies and cause lots of variation in the results. But the good news is in the early 90s, the FDA and NIH removed this exclusion of women from clinical trials. And since then, we learned lots of very important things when it comes to differences between men and women. But unfortunately, even today, only 1/3 of clinical trials include women, and 2/3 of clinical trials still focus mostly on men. So what have we learned in the last 30 years? So one of the main things that we learned about the differences between men and women is that women's hearts are different compared to men's. What that means is that the women's hearts are actually smaller, their heart rates are higher compared to men, and also their vasculature or blood vessels are smaller compared to men. Because of that, and for this reason, heart disease may also look different in women and possess different symptoms, as you will hear soon from Dr. Kirshenbaum. For the same reason, testing and diagnosis can also be different between men and women. And what we know today about testing is also based on research in men. And that's why women many times can go underdiagnosed and their treatment can be delayed. We also know that heart disease is considered to be a man's disease, and the reason for that is that heart disease in women appear usually 10 years later compared to men. So if the average age for heart disease in men is 55 years of old, in women it's usually around 65 years of old. And the reason for that is that women before menopause has hormonal protection from high levels of estrogen, which is being lost after menopause. Another thing that we learned is that some risk factors, such as smoking, diabetes, hypertension, and even family history, can actually carry stronger relative risk for women compared to men. But in addition, we also know that women can have specific risk factors that do not exist in men. For example, pregnancy complications. So, for example, women that have high blood pressure or gestational diabetes and even preterm delivery have higher risk for heart disease later in life. Similarly, other risk factors such as mental health or, for example, autoimmune disease can also possess higher risk for women compared to men. But the good news is that up to 80% of heart disease is preventable and actually can be changed by basically managing risk factors. This includes basically managing our diabetes or hypertension, participate in more exercise, healthy eating, managing our stress, and even get regular checkups at the doctor. Risk factors also work in multiplication factor, which means that if, for example, we have 3 different risk factors, we have 9 times more risk for heart disease. But if we remove one risk factor and have, let's say, only 2 risk factors for heart disease, then our heart disease can be increased by 4 times, which means that even removing one risk factor can significantly influence our risk for heart disease. So basically, there is a lot that we can all do to help reduce the risk for heart disease. And heart disease is largely preventable. And that's what I would like you all to remember today. And also, in order to be able to take care of others, we first need to be able to take care of ourselves. Just like in the airplane, we're required first to put the masks on ourselves before we put it on others. And that's why we need to start the conversation with women in our life today in order to increase knowledge and increase awareness and reduce the risk for heart disease. Thank you.
Thank you very much, Ina. So Ina mentioned about heart disease being different in men and women with respect to presentation. We're going to hear now from Dr. Kirshenbaum Liu, who is an interventional cardiologist and who looks after patients. She's going to tell you a little bit about heart disease itself, its presentation, and potentially how we can potentially treat it. So Dr. Kirshenbaum Liu is an interventional cardiologist at St. Boniface Hospital. She's a clinician scientist and an assistant professor in the Department of Internal Medicine and the Department of Community Health Sciences at the Max Rady College of Medicine. And it looks like Dr. Liu has brought some props with us. She got to show to us today, maybe even a catheter. So I'll bring Dr. Liu up and she can tell you a little bit about the clinical application and treatment of heart disease. Dr. Liu?
Thank you. Hi, everyone. Thanks for joining us here today, either braving the cold or joining us online. My name is Kirshenbaum Liu. You can hear me okay? Yeah, my name is Kirshenbaum Liu. I'm an interventional cardiologist at St. Boniface Hospital. For those that don't know what that means, to put it very simply, I am a heart plumber. Cholesterol can build up in the arteries of the heart and cause blockages. My job is to go in and open up these blockages because these blockages can cause chest pain for symptoms, reducing their quality of life. It can also cause heart attacks. So I go in, open the blockages to help the patients feel better, to stop the heart attack, to improve their quality of life, and hopefully also improve their long-term outcomes. So how do I do that? Well, I'm going to do some magic tricks. No, I'm joking. I brought some props to show you how we do that. So the procedure is called a coronary angiogram or a heart catheterization. Some of you may have had it or know people that have had it. So it's a procedure that we do pretty routinely when patients have symptoms that may be heart attack or even chest pain. So I obtain access through either the artery in the wrist or in the leg to go up to the heart. And this first thing that I want to show is the sheath that we use to get access to the artery. You can see it's fairly short, fairly small, not that scary looking. After we get access into the artery, I take a catheter or a tube all the way up to the heart. So that's what this represents. This is going to be going through my wrist, all the way through the arm and to the heart, and I inject contrast dye and x-ray through this so that I can take pictures to see where the blockages are. Once I identify where the blockages are, I use balloons and stents to open them up to restore flow, and I'm going to put this down to pull out the stent. So I use balloons and stents to restore flow. A stent, anyone can come up and look at it afterwards. It's on the paperclip. It's not the paperclip itself, but the stent is a very small metal mesh that is coated with medication. Once the stent is placed in the heart vessel, medication gets released to help the vessel stay open and hopefully blockages not form in that area. So that's a coronary angiogram. I thought a little bit about what I want to share with you today in my 5 to 10 minutes, and there are two messages I would like to share, echoing what Dr. Rabinovich-Nikitin has already said. One is knowing your risk. That is probably one of the most important things as a cardiologist I can share. Know your risk. The second message is time is muscle, and now I'm going to go a little bit into each one. So knowing your risk. There's lots of risk factors for heart disease. Some of them are modifiable and changeable, and other ones cannot. As you have already heard, heart disease can be prevented. So what are things that we cannot change from a risk factor? We can't change our age. As you get older, your risk of heart disease goes up. No way around it that we know of yet. The other things is gender. So females often are protected from cholesterol-based heart attacks when pre-menopause. Before going through menopause, the hormones actually can help to protect us. After menopause, women's risk goes up similar to men. Men overall do have a higher risk of heart disease than women for the most part. Other things we can't change, ethnicity and family history. Those are the things that we are stuck with. So what can you change? How can you prevent heart disease? Well, some things we can. So one is living a healthy lifestyle, eating healthy, exercising regularly, 150 minutes of moderate intensity exercise every week in different combinations of time is considered a healthy lifestyle. Knowing whether you have diabetes, high blood pressure, cholesterol, being treated for them to help reduce your risk of heart disease. Smoking, not smoking, reduces your risk of heart disease. These are the things that we can change about ourselves. We can encourage our loved ones to change to help reduce the risk of heart disease. So a lot of cholesterol-based heart attacks, these risk factors are so important for us to pay attention to. But I do want to focus a second on back to women's heart health, because hormones play a big role in the risk factors for women. So I already mentioned that most of the time before menopause we are protected from having heart disease, but that's not true for every single heart condition. And my clinical and my research interests, one of which is heart attacks without obvious obstructions. It's called MINOCA for short, but it's basically the patient has symptoms of a heart attack, they have blood work that suggests their heart muscle is damaged, but when we go in and we do the angiogram, we don't find an obvious blockage. There's nothing for us to stent to fix, but the patient still had a heart attack. Those patients still need to be treated to the same extent of giving the same advice about healthy living, the same medications to lower cholesterol, the same medications to prevent a future heart attack. There are other conditions that occur more so in women, possibly related to the hormones, one of which is spontaneous coronary artery dissection, or SCAD for short. So this is a condition not related to cholesterol. It is caused by a small tear in the artery of the heart. The ratio of female to male that get the condition is 9:1, which leads us to believe that there is a hormonal component to it. The average age is also much younger than patients that get cholesterol-based heart attack. The average age is around 45. So it's something that can affect the very young patients that previously we thought were protected, but turns out is not true for every heart condition. So what can you do to reduce your risk? Well, talk to your doctor. Make sure that you're being assessed for these conditions. Eat healthy, exercise, be physically active. These are the modifiable risk factors to reduce your risk of having a heart attack. The second thing I want to focus on is time is muscle. This is probably an even more important message, because if you think you or a loved one is having a heart attack, every second counts. And the reason for that is when a blockage occurs during the heart attack, oxygen is not going to the muscle of the heart. When that happens, permanent damage can occur, leading to poor quality of life, more complications, longer hospital stay, and worse outcomes down the road in things such as congestive heart failure. So symptoms that patients have can vary widely. The classic symptom that you hear about, see in the media, that we learn about in medical school, is having central chest discomfort, a heaviness or a pressure in the chest. And often when you look at ads for heart attacks, that is what they depict, a man leaning over having chest pain. They don't always have chest pain though. Sometimes it's pressure, sometimes it's heaviness, sometimes it's a sharp or stabbing pain. A lot of patients tell me it's not a pain, it's a discomfort. Often it could be more burning as well, and that makes it very confusing for patients because they don't think it's the worst pain ever, it can't be a heart attack. Unfortunately, that's not true. Some patients may not even have chest pain or discomfort. They may have shortness of breath, nausea, vomiting, feeling like their stomach is upset, cold, cool, clammy, sweaty, lightheaded. Any of these, along with some type of chest discomfort, is always a red flag to me. And I tell all my patients who is at risk or having had a heart attack, you need to watch out for any of these symptoms. Anything that you have that is new needs a workup, needs to be figured out. So one thing I do want to mention is my particular interest in research, besides women's heart health, is to really understand why patients don't present right away. And I think a lot of it comes back to not understanding the symptoms, thinking, it can't be me, I don't have risk factors, I'm too young, this must be acid reflux, downplaying their symptoms because they don't want to bother others, emergency department's busy, I don't want to be a bother, all of these things. But like already mentioned, you have to take care of yourself. So it's important to recognize these symptoms. Chest pain or discomfort could also be jaw, arm, or back. Shortness of breath, dizzy, lightheaded, excessive sweating. These could all be symptoms of a heart attack. So our recent, my team's research showed that for patients with Manitoban patients with a heart attack, from the time of symptom onset to the time they call 911 or go to the emergency department, that average time is 2 hours. Heart damage can happen in 20 minutes or less. And our patients, our loved ones, our family, our friends are waiting an average of 2 hours before picking up the phone or going to the emergency department. So last year I led a public awareness campaign called Dial Don't Drive to educate patients, the general public, about the symptoms of a heart attack and the concept of time is muscle, that every second counts. I think a lot more work needs to be done in this area because a lot of patients, potential patients, do not know this. We need to do a better job of spreading awareness and to be able to educate and empower patients that when they think they have a heart attack, they need to seek help right away. So to summarize, know your risk. Talk to your healthcare provider. Don't be shy. Don't be afraid to mention it. Eat healthy, live healthy to reduce your risk. And the second thing, time is muscle. If you think you or a loved one is having a heart attack, dial Don't Drive. Get the help that you need. So thank you for your attention, and turning it back to Lorrie.
Thank you very much. Thank you, Dr. Liu. That was very, very informative and great combination of symptomology and treatments. That was really, really great. All right, so part of this discussion this evening was to not only be an information session in terms of women heart health, heart disease, and treatments, we're also going to talk a little bit about the research that's ongoing. And so we have with us this evening Dr. Bradley Doble. I've known Brad for many, many years, although one of the first times seeing him again this evening, so welcome, Brad. Brad is an associate professor and the Beeler Chair in Stem Cell Research in the Departments of Pediatrics and Child Health and Biochemistry and Medical Genetics at the Max Rady College of Medicine, Faculty of Health Sciences. His talk is going to talk, his lecture this evening, or discussions this evening, is really going to focus on different models of heart disease and how you can make models to basically develop new therapies to treat damaged heart muscle that would occur after a heart attack. So with further ado, I'd like to invite Dr. Doble to the mic tell us, or if you want to sit where you are, whatever you're comfortable with, and tell us a little bit about your research.
I'll sit to be different.
All right, thank you.
Thanks, Lorrie. So my talk is quite a bit different because I'm actually a stem cell biologist with a background in cardiovascular sciences. I was actually in the same institute that Lorrie runs now. For my PhD, I was away in Ontario for 20 years and came back in 2019 to further study stem cells in various contexts. So for you to understand what I do, I think I have to go back, way back in development. So we all started from one cell. So that first cell has a nucleus in it. So it's the fertilized egg, called a zygote, has a nucleus that has all of the information for every single cell in our body, and has all the information for putting all those cells together at the right time, in the right order, and in the right configuration to make all of our organ systems and all of our tissues. So that's a very complicated system. And the nucleus in that one cell is 1/100th of a millimeter in size. So all of that information that makes a human is crammed into that tiny little thing. So understanding how that information is translated from that tiny little nucleus into all of the organ systems of our body is kind of part of my research, which focuses us on stem cells. So the type of stem cell that I study is called a pluripotent stem cell. So these stem cells have the ability to make all different cell types. And they come from a really, really early embryo, potentially. So those are called embryonic stem cells. So that's a day 3.5 embryo, which is about 1/10 of a millimeter in size. So really, really, really early embryo. So those embryonic stem cells, so some were derived from humans, but there were ethical concerns about that. And, rightly so, potentially, depending on when you think life begins. So in 2006, an investigator from Japan called Shinya Yamanaka developed a technique, and I was actually at the first International Society of Stem Cell Research meeting in Toronto in 2006, where he gave his talk, and he described being able to take a skin cell, so a single skin cell, and change it into a pluripotent stem cell with only 4 factors. And you would think that everybody in the audience would be going crazy and clapping and wow, that's amazing. But it was more like people didn't believe it, and it was just like silence. But flash forward, he got the Nobel Prize, and everybody, many researchers are using induced pluripotent stem cells now. So this is the way we can take, so the initial stem cells were from skin. Now it's much easier, so people don't want to give you some of their skin, but they're okay with giving you some of their blood. So you can take a sample of blood, collect the white blood cells, the mononuclear cells, and using these 4 factors, you can change those blood cells into these pluripotent cells that have the ability to become any cell type of the body. And some really amazing things have been done with these cells to date, and these things are just getting more amazing. I was just at the Canadian stem cell meeting that they had a little bit a few months ago. It's really, the way this artificial intelligence and everything is going, science is also the same, exponential growth. But we can take blood cells, convert them into these pluripotent stem cells, and then make any tissues, including cardiac tissue. So 3 investigators here at the University of Manitoba, and I'm one of them, put a grant in with the idea of taking from patients that have genetic heart disease that is not well understood, taking their blood and converting it into cardiac tissue. And then one of the investigators he is actually a bioengineer, and he has a very cool 3D printer where he can print out cells. So he actually makes cardiac tissue from these cardiac cells, which allows us to look at all of the parameters that you would look at for any sort of cardiac tissue, how well it contracts, electrophysiology, and we can also start looking at mechanisms of that kind of genetic disease that we don't understand. So I think that's where I'll leave it at this point. Really open to any questions.
All right. Okay, thank you very much. That was great, Brad. It's really quite fascinating because, you know, we talk about reverse engineering. We talk about bench to bedside and bedside to bench. So we have a clinical problem. Someone shows up with heart disease or symptoms of heart disease. They would see someone like Dr. Lou in the clinic. We would find out what would be wrong with them. They'd identify that we have a heart attack. And it would be people like myself who are interested in understanding mechanisms of cell death that would understand the research. People like Dr. Nidekin would be looking at why that occurs in sex-specific manners, and then researchers like Dr. Doble, who basically are looking at ways of regenerating cardiac muscle and or using the cells themselves to study genetic disease. So you can see that there are multidisciplines that actually work together from different fields to study one form of heart disease or another. So I hope the discussions this evening were quite interesting. I believe we have time for some questions. We can have questions of our panelists from here in the audience. I believe there'll be individuals online that might be asking questions. So the floor is open to individuals who may have a question. Yes, sir. And I guess there's going to be a mic floating around, so please wait for the mic so that you can ask your question. Sir, go ahead.
This is a question for Dr. Lou. You mentioned spontaneous coronary artery dissection was more common, 9-to-1, between females and males. Is that correct?
Yes.
Okay.
Yeah.
The second question I have is, what's the mechanism for diabetes mellitus influencing atherosclerosis?
So I think that's a great question. There are probably, I would say, multiple theories, and you're going to hear this a lot from me this evening, which is that it's not completely understood, but the high blood sugar can cause inflammation, which can accelerate atherosclerosis or the cholesterol building up, hardening of the arteries, that process. So often we do see that patients with diabetes can more quickly develop atherosclerosis, especially type 1 diabetics starting from a very young age. It's not unusual that on a day that I'm working clinically that I may see patients who are 30, 35 years old who have type 1 diabetes from a young age, have arteries that look like a 70 or 80-year-old. So definitely that having that high blood sugar, the chronic inflammation does play a role. Diabetes can also be associated with other heart conditions, including heart failure. So I think there's probably different mechanisms that affect the myocytes in the individual cells as well, beyond just atherosclerosis.
Okay, I was concerned about diabetes in coronary artery disease as opposed to cardiomyopathy, which is the mechanism in chronic heart failure in diabetics. Is that right?
So yes, cardiomyopathy so there's different types of cardiomyopathy. It can be completely unrelated to atherosclerosis, so unrelated to heart attacks. Sometimes it's genetics, sometimes it's related to viral infections, alcohol use, drug use, and etc. However, the most common cause is from atherosclerosis, and it's sort of the end stage of almost all types of heart disease.
Thank you.
Okay, thanks very much. Any other questions? We have one question here.
Hi. Thank you very much for a wonderful talk, discussion. It was very interesting. This is for Dr. Liu, or actually anybody on the panel. Is there any work that's being done on checking out markers through blood tests for different types of coronary artery disease development?
So I think there are. So I can give you an example. It's not my primary area of research, so I wouldn't be able to sort of expand on it, but perhaps these two, all three of these experts may know a little bit more about biomarkers than me. But for example, for the spontaneous coronary artery dissection patient population, it's really only been diagnosed for about last 10, 15 years. There's so much we don't understand about it. So in one of my collaborations with a colleague, we are collecting blood samples to be able to look at different biomarkers to try to understand further why these patients may have it. We're comparing it to other patients who have atherosclerosis or cholesterol-based heart attack to be able to see what particular biomarkers may help us identify patients at risk of having this condition. But from more further understanding of inflammation playing a role, there's definitely been more use of inflammatory markers such as CRP, ESR, which are also routine markers, and they do add to both the diagnosis of heart disease, the risk assessment of heart disease, as well as patients' outcome after having a heart attack. So definitely there's a lot of work in that area. Just for me, we are using it in our research team more related to unique and rare women's heart health conditions. I don't know if anyone else has anything to add.
I can jump in. So for the general public, as Dr. Liu had mentioned, when someone is potentially having a heart attack and their blood is taken, classical markers of heart attack are things like LDH, lactate dehydrogenase, or high sensitivity troponin are measured in the blood. And these are proteins that are released by the cells of the heart when the heart muscle becomes damaged. So once it's starved of oxygen, the heart muscles start dying, they start breaking down, and proteins or enzymes are leaked out of the cell, and they go into the blood, and we look for them. They shouldn't be there ordinarily, and if they are, very, very low levels, but they peak very high. So based upon the levels in the blood, we can tell if a person is having a heart attack or not. But one of the things that we're looking at now are new biomarkers. So these are potentially new proteins or early indicators that a heart attack or heart damage is occurring. And so the current gold standards that are used, we're looking for things that are even markers that are even more sensitive, not only to determine the extent of the injury very, very early on. Sometimes, as you heard from Dr. Liu, that a person can be asymptomatic, but we also want to know what happens after the intervention takes place. So Dr. Liu would put the stent in, revascularize or reinstitute the flow to the individual. We will take their blood, and we want to know if in fact the enzymes or these blood levels are decreased. And sometimes these markers aren't sensitive enough to predict success. So that's what we're currently looking at, and this is a global interest in the field. But as our techniques in molecular biology and new techniques in terms of analysis, we can actually do this, and this is something that's currently ongoing. Does that address your question? Yeah? All right. Anything else? Any other questions?
I'd like to ask a question. This is for Dr. Rabinovich-Nikitin. You were talking about the risk factors and eliminating those risk factors whenever possible. What are the easiest risk factors to eliminate, and what are the most impactful to heart disease?
Yeah. So that's a very good question. So when we say easiest risk factor to eliminate, it's basically based on you. Like, for example, a person who's smoking, I'm not smoking, so I would say, oh, it's easy to quit smoking. So for me, that's an easy risk factor to eliminate. For other people, it might be harder. For example, I'm sorry to say that, but I'm not a big fan of sports or physical activity. So that's something that's harder for me. So it's more individual, but we need to start with whatever is easier for us individually. The harder ones is the one that Dr. Liu mentioned, that are basically part of the 20% risk for heart disease that we cannot change, and this is age, ethnicity, and family history. So that's the things that unfortunately we're still not able to change. In terms of family history, that's something that research is really working hard into trying to prevent, finding different biomarkers, and trying to improve that. Age is also, there is lots of research going on in terms of age and how it affects heart disease, and there are efforts to try and eliminate the adverse, I can't say adverse effects, but basically the effects of aging. But because I said that there is multiplicity effect for risk factors, it's important to start and try to remove at least one risk factors. Because even if we remove even one risk factor, it can significantly reduce our risk for heart disease. So whatever is easy for you, we should start there.
I just want to add that change is really, really hard. We see patients in clinic all the time having a large heart attack, knowing that they're at risk for having another heart attack, can't stop smoking, can't exercise. We're all busy, right? A lot of the patients having heart attacks have jobs, have families, and other commitments, so change is really hard. But making a very small change at a time, and I often tell my patients, just 5 minutes, make it into a habit. Do it 100 days, and just 5 minutes of changing into your exercise clothes after dinner, doing a circle during commercial around your living room. Make it a habit and then slowly build that up, because it's very difficult for anyone to make a drastic change. Eat, never have deep fried food, never have sweets, never have salt, never do this, that, exercise this, that. It's impossible and it's not sustainable. So it's very important to make small changes that are actually going to be sustainable, that you will want to continue to do. And often the first thing that we need to do is make it into a habit before starting to add more complexity to it to reach that. I'm using exercise as an example. To reach that 150 minutes, no one's going to be able to do that in a week or two. It takes months to get to that point.
Thanks very much. There was a question here. Yes?
First of all, thank you. Thank you very much to all of you for sharing your knowledge and making it something that we can take in. I was really interested, this is I think for Dr. Liu, in your comment around how long it takes between when folks first have symptoms to 2 hours before they make a call. And I'm curious to know, is that first of all in Manitoba? And if so, and how does that compare or relate to other places in Canada or internationally? And assuming there is some difference, is there any sense of what that difference might be related to?
Yeah, that's a great question, and something that I would, if you ask me again in a year, hopefully I'll have a better answer for you. So our research was in Manitoba. So we looked at about 400 acute heart attack patients, and we found the average time was just over 2 hours. From the time that they said they had symptoms to the time that they sought medical attention. So this was going through charts to try to collect the information. And anyone that has done research with charts will know that it's just missing tons of information. There may be bias, you may not get the most accurate, but to the best of our ability, this is what we know. In the next couple months, we will be doing further research to ask patients as they come in to make sure it's documented, to collect it. So hopefully we can get better understanding of when did their symptoms start? What symptoms do they have? Because we know that patients who had sudden onset will come faster than people who had a gradual onset. People who said it was the most severe pain they've ever had will seek medical attention sooner than people who said, maybe it's heartburn, maybe it's this, I'll sleep through it. So definitely it's something we want to understand further, but the 2 hours is pretty standard. When I did a literature review looking at other countries, other studies, it ranges anywhere from an average of 1 hour to an average of 8 hours. So it really depends on the patient population being studied. So some things that we do know, elderly, female patients are more likely to present later. Patients who have barriers to health care, such as language barriers, mobility issues, are likely to present later. Patients who have patients who have a gradual onset would present later. Patients who don't have the typical chest pain would present later. So there's some, I would say, adequate understanding to be able for us as a community to try to raise awareness and educate, but there's still a lot that we don't understand behind the partly the psychological mindset of patients to, when they think it's severe enough for them to present. I think those are the two questions, Manitoba and other places.
I would just like to add that, and correct me if I'm wrong, but as far as I know, women also tend to take longer to get medical help compared to men. And most of it is because of awareness, because still many people don't know that women can have heart attacks. And that's why we need to have these kind of events in order to increase the knowledge and awareness, and to start talking to our family members, so that if even women have specific symptoms, we shouldn't just dismiss it. Or even if they go to the doctor, sometimes even the doctors say, oh, you just have anxiety, don't worry, you have a very busy life. So once we become more aware of our health and our risk factors, we're able to go to our doctors and say, no, I feel that something is wrong with my body. Or if I see someone in my family is feeling bad, say, no, it actually can be heart attack. So I think there is also a very strong sex difference component.
So definitely, I think that there's two parts to it. The first is the patient needs to seek help, right? If you don't seek help, we can't make the diagnosis, we can't start the treatment. Definitely, there's still, I would say, a difference in patients. I'm just trying to make sure I convey the right message. So the blood work does not lie. The ECG, the heart tracing, does not lie, but you have to order the test to be able to interpret them, right? So sometimes women, perhaps just the way I think a lot of women patients, they may dismiss their symptoms. They may think it's not important. I hear that I don't want to bother anyone quite a lot. And so the way the communication happens, and perhaps, not speaking up quite as much in using the terminology that is required for people to think, oh, that could be a heart attack. So that can sometimes lead to a delay in getting the test. But once the test is done, the numbers speak for themselves. If that biomarker, like Lorrie mentioned, that represents heart muscle damage, if that is up, that is up. If the ECG shows a massive heart attack and there's no blood flow to a certain area, that does not lie, but someone needs to order those tests. Someone needs to think about it to be able to start down that path. But once the diagnosis is made, often there's less of a delay in patients getting the treatment that they need, whether it's male or female. So I think there's multiple parts to the sex differences.
Again, one of the things that we wanted to bring forward this evening was the awareness. And part of this Women Heart Health Research Program and initiative is really part of education. And one of these wonderful anecdotal stories that came from one of my colleagues in the U.S. had a woman present, and the only symptom, and this is one of the concerns, is that, a person could be asymptomatic. She had a toothache. And basically that was it. And so he recognized immediately she was having a heart attack in the office because the classical jaw pain wasn't there, the radiating pain wasn't there in the arm, but she had a toothache. And I think the biggest thing, and any of the physicians watching or in the room will know, and Shangbo will tell you, that the first thing and the most important thing is the history. Is taking a history and asking the patient if it feels different, or is this different, or have you had it before, or is it new? That's the key. And unfortunately, this is the education we're trying to convey, is that sometimes that goes overlooked. Are there any other questions in the room?
We have a question from our online audience. Dr. Liu, if there are occasional feelings of chest tightness after a meal and some extra warmth at the same time, and this feeling lasts only a few minutes and then goes away, does this indicate something about a heart issue?
So I can't give specific medical advice. That would be my first disclaimer. So there is postprandial angina. So that's a fancy medical term for chest pain that occurs after a meal. And part of that is because the blood is diverted to the stomach to help with digestion. And so if there are blockages in the heart, not enough blood is going to the heart, it can cause chest discomfort. Fairly rare. I think that if the person online asking this is having those symptoms, the best advice I can give is talk to your healthcare provider. Don't ignore it. Anything, like Lorrie just said, anything that is new, anything that is unusual, anything that came out of nowhere, that needs to be assessed by someone, starting with a history, a physical exam, and investigations as needed, but I would definitely not ignore it. Are we allowed to ask questions?
We're allowed to ask questions.
Can I ask Brad a question?
You can ask Brad a question.
I feel like I've been in the hot seat. It is very hot up here. How long does it take to turn a single cell into a model?
So that's a really good question.
I'm a very impatient person.
So the issue with these cells is that you really have to do a lot of quality control on them once you generate them. So from a blood sample, you will end up with multiple colonies or clones of these stem cells. And it's in a matter of weeks. It doesn't take that long to get the first clone. But then you have to make sure that they have all the properties that you need them to have. So if it's a pluripotent stem cell, there are some kind of standard assays that are used to make sure that they can differentiate into, say, the 3 lineages, mesoderm, ectoderm, and endoderm. And you want to make sure that they don't have any abnormalities that weren't in the initial blood cells. So you would look at the blood cells. If you have a lot of money, you would do whole genome sequencing, and then you would do the same sort of sequencing on your clone. And so it really does come down to resources, about the length of time. So if you're in Harvard, a couple of months. Okay. If you're here, it could take a few years to get the grant for. But it is something that it's not impossible, and it's not years. But there is kind of that quality control check that has to be done before you can have a meaningful model.
Great. Thank you. Does that help, Dr. Liu? Yes?
Yeah, I'm
Excellent.
thinking of a collaboration already, because for some of the unique conditions in women, there's so much research to be done out there. There's not that many patients, and as most of us in research know, you need an adequate sample size to be able to understand the condition further. So I may be emailing you tomorrow.
Wonderful. Terrific.
That would be awesome. Yeah.
Any other questions?
I have another question. I actually have
Go
2 questions.
Go ahead, Diane.
One is you talked about the role of estrogen in protection of women premenopausal. Is there any role of hormonal replacement and use of estrogen postmenopausal to reduce the risk? And if so, are there potential risk factors related to that? Are there certain guidelines with respect to hormonal replacement, with respect to estrogen and heart disease? And second, is there, moving forward with your research, Brad, and is there any prospect in the future of using biofilm to protect the heart once it's already damaged, as like a mesh or something over top of damaged hearts in the future, or stem cell use in the future to be able to help hearts that are already damaged?
You go first.
So the question about the stem cells being used for regenerative medicine, that's a whole field. And it is also something that is being actively pursued by many groups. One of the things about the heart is that it's not just one cell type. It's not just the cells that are doing the contracting. It has many other cell types, including the vasculature. And one of the labs that I know quite well in Toronto has been trying to develop kind of patches for for hearts that have had damage, excising the damaged heart, and putting these patches on. And one of the issues initially was that they couldn't get a thick enough stem cell derived piece of tissue because it was grown in a single layer. But they developed what they call cellular Velcro. So it's another bioengineering group, but they were able to kind of stack layers of the tissue into kind of a patch. And that has been more promising than the initial attempt. But one other kind of interesting thing, so this is very different, but it's something that they're also working at that's not stem cell related. And some people might be really kind of not thrilled about the idea of it, but there is the idea out there of taking pig hearts, which are very similar to human hearts. And there's a lab in Harvard, actually, that is manipulating the heart using a technology called CRISPR technology to humanize the heart so that it would not be rejected when put in. So it means that you don't have to wait for a human donor for an entire heart. You could grow them in pigs and have these humanized hearts that have also been manipulated so that they don't have something called an endogenous retrovirus, so that they'll, won't give you viral complications. But that's also another approach that is being thought, where kind of pick an organ off the shelf that has been grown in a pig. So things, like I say, are getting very, 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 very strange. The technologies of recent times are, they're amazing. They're, personalized medicine that is tailored to individuals is getting more and more prevalent, and these technologies are allowing that.
I want to comment, I want Dr. Liu to address the issue of pre- and postmenopausal and estrogen replacement therapy. I want to make sure we have enough time. But if there is some time at the end, maybe we can talk a little about precision medicine and where things are going with artificial intelligence, et cetera. So Dr. Liu, do you want to address the hormonal replacement therapy question?
Sure. So taking the theme of precision medicine, it's all about the individual. So before, we used to probably, we physicians in general, probably prescribed hormone replacement therapy more than now. And part of that is the research has shown controversial results, and therefore it has become a bit more of a hot topic. So it really comes down to the patient's individual risk of whether they should be on hormone replacement therapy or not. From a just giving an example of why it needs to be personalized. So in the SCAD patient population, so that dissection, heart attack, being on hormone replacement therapy is actually a risk factor for SCAD, and it can increase the risk of recurrence because of that hormone imbalance theory. So there are patients, I've had patients who have been on hormone replacement therapy or oral contraceptives for many years, and that's really the only risk factor that we identify. SCAD also happens more during pregnancy or immediately after, or times of menopause. So it's while hormone replacement therapy does have a role in certain patients, in other patient populations, such as for SCAD, it's actually generally contraindicated. So I think precision, I'm trying to now turn the attention to precision medicine, because we really need to individualize everything. I may see 10 patients that have the same condition, they all have had SCAD, but the advice I give them may be slightly different depending on their risk factors, what type of disease, where was the lesion, what is their risk of recurrence. And I think that through more research into different biomarkers, understanding the natural history better through modeling, through lab work, it really helps the clinician to be able to give the patient a specific risk unique to them. There are certain tests and certain certain tests and certain scoring systems that we use to try to generalize that risk, but nothing is as good as if the patient were to provide, let's say, a blood sample. We run the test, and I'm like, in 5 years, your risk of heart attack test is this, and this is unique to you. So I'm kind of answering your question, but not. But I think it really depends on the patient. We're probably using hormone replacement therapy less than we did previously due to some conflicting evidence. But I think the way of the future is to be able to do research like these researchers are doing, so that I can sit in the clinic and give you your individual risk.
I would just like to add that one of the main reasons that women are prescribed with hormonal therapy is to treat the symptoms of menopause. And one of the main symptoms is hot flashes. So I just read this week that there is now a new treatment that was just recently approved by the FDA that is not hormonal based to treat hot flashes. So there is hope that we will be able to use not hormonal therapy, but something similar to treat the same problems that we see with menopause.
Great, that's wonderful. Any other questions? Anamika?
Yeah, I have a question. So early on this evening, you mentioned that much of what we know about heart disease is based on men. And there was also a conversation about that, the heart size is different for women and men. Symptoms might be different. And I wonder, in terms of treatment options or impacts, is that also dependent on male versus female? And I'm talking about binary system here. But I'm just wondering, are certain treatment options better for women than for men, and vice versa?
We just wrote a paper about it, the three of us.
Yes. Do you want to talk about it?
I didn't know that, but that's good.
It's not published
this
yet.
Wasn't the planned.
Yeah.
This wasn't the planned question. So the three of us just co-authored a manuscript on this very topic. So do you want to talk about it?
Yeah. So it's not published yet. I will be happy to share it once it's published. But
maybe I can be a reviewer of the manuscript.
Yeah. So yeah, we actually summarized the most common treatments for heart disease, and there are some treatments that are better for women compared to men. Also, some treatments have more risk for women compared to men, so it's very specific. Most treatments today are considered okay for both sexes, but there are some differences and benefits, and that's why, again, many times it's better to consult with your doctor.
I just want to add that... now I've forgotten what I'm going to add. Mom brain. I just want to add to something that Ina mentioned when she was speaking up there, which is a lot of the research into these medications were done in men. Even now, despite a very needed but aggressive push to enroll women into clinical trials, probably most of our heart attack trials, the large trials, 20% or less are women. So a lot of the generalizations we're making about these medications working are, they're based on 80% of men in these studies. So we're somewhat extrapolating to women in terms of the medications working. A lot of the studies now the clinical trials are trying to enroll more women. There are quite a few researchers in the heart attack field that look at sex and gender differences in terms of heart attacks and treatments, and that is very needed. 2 of the studies I'm involved in are enrolling just women. So definitely this is an area that is continuing to expand and grow, and I think very necessary. Once you read the paper, you'll see a lot of we're just like pushing this paper out there.
It will be open access, so we don't earn anything from that.
But I think more women need to be in the clinical trials. They need to be thought of. They need to be approached. There may need to be clinical trials of just women. And a lot of the medications, the mechanisms are going to be similar, but like Ina mentioned, the side effects may be different. The rate of the side effects may be different. And anytime we're counseling patients about the medication, every patient's, their risk, their assessment of the risk is different. I may be telling the patient the same thing, 1% risk of blah, 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 but how the patient interprets that may be very different. And so knowing exactly, again, I love the idea of precision medicine. So being able to give a patient an exact number would be magical, I think, for both the patient and for me as a clinician. But definitely more women should be in these clinical trials for us to be able to say that.
I was going to mention that our heart attack research involves both sexes, males and females. And in fact, the majority, if not all funding bodies, Canadian Institutes for Health Research, CIHR, Heart and Stroke Foundation, many others, actually require both sexes to be considered. And so that we're recognizing that in the past where you studied male cells from an animal and you looked at it at a dish, and now you're looking at female cells, unless you were looking at them in parallel, you would never have noticed that there are fundamental differences. And it's really rudimentary for us, and very, very exciting to see that there is opportunity to treat women and females differently than we were in the past. You had a comment?
Yeah, so I actually had two comments. So when we talk about side effects, it's true not only for treatments for heart disease, but basically for any kind of treatment, because today we know that different enzymes we have to process or metabolize different drugs can also be different between men and women. Some of them are expressed more in men compared to women, and that's why the drug can be metabolized quicker or slower and cause toxicity or not a very strong effect. And in terms of the clinical trials, I just wanted to highlight that unfortunately, we don't see too many women in clinical trials also because women are not engaging into the clinical trials. So they basically, from the reports I saw, they don't find the time or they don't find it important enough to engage into clinical trials. And that's why it's also so important to increase the knowledge and awareness in order to encourage women to go into clinical trials.
Any other questions?
We have a question from our online viewers.
Sure.
This is from Amy. Is it normal to feel chest pains consistently every day, even at random times? For example, pain persists for over a month since an emotional distress occurred. What would qualify as a heart attack? Or how would we know when to call for help, especially for a patient who hasn't had or experienced this before?
That's you, Dr. Liu.
I think it's a short answer.
Short answer.
I think any time that you have a symptom that is new, it needs to be looked at. So talk to your healthcare provider. I think that any amount of chest pain that has not been worked up, not been assessed, is always concerning. So I think talking to your family doctor, primary care provider, nurse practitioner, whoever it may be, is very important. And I'll leave it at that.
Any other questions?
I have a question. You all kind of talked about the importance of public awareness in different aspects based on your research. I'm wondering what you think we as the public should take away from the key takeaways that we should spread to our network and our communities.
Can I address this?
Absolutely.
So it's very interesting. It's just talking to family, talking to friends, and trying to be more aware. So on Sunday, past Sunday, on the 25th, we organized, there was a Women Heart Health program at the Dakota Rec House, Field House. And it was attended by many people, and there was an ad in the paper and advertised and that sort of thing. But the turnout was very, very good. And when people did show up, there were demonstrations of hearts, and there was Zumba for heart health, and there was educational programs. But it wasn't attended as if we had 500 people. But it's a very, very small understanding that the education of individuals is what we're really trying to go after. So the take-home message this evening is that there's a very, very strong concerted effort in the medical community for research, for patient care, for patient advocacy, and for translating that research into better patient outcomes. So we reduce the risk, we reduced the burden on our healthcare system. So I'll just give you an example. People who have heart attack type symptoms or similar and they have damaged heart muscle. If the heart muscle itself doesn't remodel or change itself to repair, the person ultimately develops heart failure. And heart failure is a form of heart disease that just means simply that the heart's ability to pump blood is decreased. Heart failure has no cure. It's either transplant or palliative care. And there are many, many people living with heart failure. They're short of breath, they require some drugs, etc. But it's a costly burden on our healthcare system, not only to the individual that has the heart failure, but to their families, their healthcare providers. So it has a multiplier effect. And part of this forum this evening and some of the other forums and workshops we've had is to educate the public why research is so much needed and important and in different areas. And you can see how research evolved from just understanding the heart attack symptoms, which we know very little about now as you're learning, to treatment, and then individuals like Brad who are able to 3D print a heart, you know. And so it's really, really cool, and this is how medicine is evolving. But the idea here is awareness. And I gave you this very long, convoluted answer, but this is what the umbrella is and why it's so important that these programs occur and people like you asking these wonderful questions.
Thank you.
I want to add my 3 words: time is muscle. If you think you're having a heart attack, if you think your loved one is having a heart attack, don't wait, don't hesitate, don't think you're going to bother someone or it can't be that bad. I'm just going to do the dishes, sleep through the night, whatever it may be. Seek help, and the best way to seek help is to call 911. Don't drive yourself to the emergency department.
And Amika?
Yeah, I have another question, and I wonder, in terms of the incidences of heart disease per population, how has that changed over time? So if I think about the 20s and the 30s, everyone was smoking, if you look at the old movies. Now hardly anyone is smoking, except, I guess, for the vaping that is going on. Diet has changed. I think we now much more rely on fast food than in the past. But people also get older because we have a lot of better treatment for a variety of diseases. And are there any statistics in Canada or worldwide that actually show the incidences over time?
So maybe, maybe I can refer to it. So we actually know that for men, heart disease starts to a little bit decline, but for women, it's on the rise. So statistically, it is increasing with years because, as you mentioned, our lifestyle is changing. So maybe less people are smoking, but we are eating less healthier than before, more stress to our life, which also adds to heart disease. So yes, unfortunately, we do still see increase in heart disease. And if we don't start to change our lifestyle, it won't change so quickly in the near future because treatment is, and maybe that's something that you can talk about, it's not going to come out tomorrow.
Actually, I have a question for you.
I thought that you wanted to argue with me that it's going to come tomorrow.
No, I was just thinking of all of these drugs that people are taking now, ostensibly for type 2 diabetes, but a lot of them are just using it for weight reduction. So how are those, what does the heart health community think of these types of drugs that are being used more and more commonly?
Yeah, I'm just going to add a comment to what Ina just said about the incidence of heart disease. One thing that, the other thing that has changed in addition to, fast food is really just convenience, right? We're more likely to take the elevator. We are more likely to drive rather than walk, right? So the physical activity has really decreased. You really have to make a conscious effort to add that to your life because it's much easier to hop into that elevator that I'm staring at, or I live, 5-minute drive from here. Maybe I could have biked here, probably not tonight, but different things like that. A lot of the time we are so busy in our lives, we're trying to do so many things. The easiest thing is to get into the car, not thinking about could I bike, could I walk, and etc. And that also increases the risk of heart disease. Like you said, people are living longer. We're putting stents into 80-year-olds. Cancer is being better treated. So with increasing lifespan, we're going to see more patients with heart disease for sure. The other thing that has changed compared to even 10 years ago is our ability to detect heart disease. We have very high sensitivity tests now that will, if I push Brad and it causes him to have palpitations, his heart goes into a fast rhythm, we do the blood work, the enzyme would be up It is so sensitive now. It's rare for us to miss a heart attack if the blood work is done, but we probably overcall it when we wouldn't have called it before. The patient may have been, oh, you're okay, it's not a heart attack, because that test wasn't that sensitive. But now that test will detect everything. So we are probably diagnosing more heart attacks, smaller heart attacks, as a result of our improved technology. Back to your question, which was using some of these off-label medications. So I think aggressive, quick weight loss, again, probably coming back to convenience, it's much easier to take a pill than to exercise and et cetera and maintain that change. But any rapid decrease in weight actually is not healthy for the body. It should ideally be done over a slower period of time, and not just for the heart. It can cause other things like problems with the gallbladder, the gut, and et cetera. But some of these medications are so new, they're not well understood. Whether their effect on heart attacks, on heart failure, on dangerous rhythms of the heart, we just simply don't have that evidence. And we only have very short follow-up for some of the studies. Some of the studies are only looking at 30 days. They're not looking at 3 years, 10 years, 15 years down the road, because we just don't have that evidence. But for those, I'm trying to remember what the diet pill was called back in like the 1970s that everyone took, and it turns out that it caused tons of heart problems. I'm worried that as some of these newer medications come out, are we gonna have replication of that? You remember? Fen-phen, thank you. Back to my med school days, yeah. So some of these medications that are coming out now are so new. They're continuing to be studied. There's always post-market research that is ongoing. And if you need it for an indication, a clear indication, you fit into that study population, then yes, that makes sense for you to take that, because the risk and the benefit makes sense. But if it is just used for other purposes, then I think that it's a lot of off-label use. We don't quite understand it. We don't know what the risk is in the long term. There are even not medications, but even like cannabis, like weed, right? We're still trying to understand that effect on the heart. A lot of people are using it. People ask about e-cigarettes. These are all hot topics in cardiology because we don't understand it. I'm going to now turn the question back to you. If you have a model, could we give them these medications, these drugs, and et cetera, to understand the effect on the heart and the natural history?
Yeah, so that's kind of one of the points, is that if there's a genetic cause, so the samples that we're working with, they have a known clinical presentation, but they also have known genetics. They just don't understand why the genetics are linked to the heart disease. They think it's something to do with the mitochondrial function. So the idea is, you can't take a piece of somebody's heart, but you can take their blood, make it into the heart that has the same genetic defect, and test it, and test drugs on it. So that's
good and bad drugs.
Good and bad drugs, yeah. Yeah.
Just one more comment. So you mentioned about smoking, that people are smoking less these days, but vaping is on the rise, and vaping is still smoking.
I wanted to also comment very briefly about the lifestyle. So we live in a very, very cold, at least today, climate. Winters can be very oppressive, and as the summers can be also very oppressive with the heat. So we have this problem with being outdoors. Some people love, if you're a polar bear, you love being outside in this weather or otherwise. And I know that in Europe, in some of the warmer countries, people are walking and they're more active, and they are going to the market on a daily basis and buying fresh fruits and vegetables, et cetera. So they don't have very large fridges as we do. And perhaps maybe there's more awareness. And I'm just wondering, from the European Heart Societies and the meetings we've been to, because this is a big area as well, do you think lifestyle in North America in general, not necessarily just in Winnipeg, has a major role in terms of heart disease development versus Europe or Asia?
Yeah, for sure. I think definitely our lifestyle. Like, lifestyle makes a huge difference in terms of the risk of heart disease and also risk of future heart disease after having a heart attack. Lifestyle is the cornerstone of every conversation I have with a patient before I prescribe any medication for high blood pressure, for risk of heart disease, all of that. We talk about diet, we talk about exercise, because really it is so important. I would say the Europeans, they probably eat better than we do, with their many hour meals and alcohol intake. So maybe it balances out. But lifestyle is definitely the cornerstone of all treatment in medicine. It's inconvenient, I would say. It's difficult. It is much more difficult to commit to eating healthy and exercising for 150 minutes per week. It is much easier to fill that prescription and take the medication, right? But medications have side effects. Medications may or may not work, as you just heard, depending on your own individual risk. But lifestyle works for everyone. And even though we live in Winnipeg, it's freezing, and walking is really the best exercise for your heart. You don't need to go run a marathon. You don't need to climb a mountain. You don't need the fanciest equipment or gym, but just walking. So I tell my patients who tell me they don't have time or they don't have a gym pass or anything like that, when you're watching TV after dinner, walk. Every time there's a commercial, for those 5 minutes, walk in circles in your living room, into your dining room. Just try to incorporate into your life. I will say exercise and being physically active are also different. Because a lot of people say, you know what, I'm on my feet, I walk 10,000 steps a day because I'm working up and down. That is not the same as exercise. Exercise is time that you set aside to get your heart rate up, to exercise, to sweat, to do that, and that is different than being physically active. Both are equally important. But I think I don't accept cold weather as an excuse for not exercising.
I was going to say go somewhere warm and...
Yeah, but also something easy to do. I saw where you parked. You parked further than I did. So when it's not this cold...
There's only 2 cars.
Okay. When it's this cold, when it's not this cold, I encourage my patients to park further. Walk a little bit extra, right? If you're in the Walmart parking lot, park a little bit further. Don't look for the closest, most convenient spot. That adds a couple steps to your day. That is being physically active. So there's so many little changes we could all do in our lives to be able to be more physically active and maybe be as cool as the Europeans.
I'm going to get myself a walking treadmill. What do you think, Annemieke? Yeah. From my office? Yes. Any other questions? Oh, sir? Oh, just a sec.
We know that cigarette smoking is bad for your heart. Is a glass of red wine 4 or 5 times a week helpful or not?
Is that for me? I don't drink.
So you asked specifically about red wine? Or
alcohol in general.
So red...
Yeah. The question was, I'll repeat it. There was a study done, the gentleman asked the question about having 2 drinks of red wine, and there was some question about wine consumption or alcohol consumption. Is that your question? Yes.
So
which one of you ladies would like to take the...
Maybe I can start.
Right.
So this research is a little bit misleading, and I will say why. Because red wine specifically has antioxidants, and specifically one is called resveratrol, which is what we have under the, like on the grape, the outside of the grape, we have resveratrol, which is very healthy for our heart. But we need to consume so much of that in order to protect our heart that it's not, I think it's not worth the risk of the alcohol. There are better ways to get these antioxidants, not through alcohol. And I would also like to take this question to food habits, eating habits. And Kirshenbaum talked about exercising and physical activity. So it's a very good question because it's actually very important to educate ourselves about food and health, eating habits. And even, for example, if we take a food package and we read the ingredients and we learn that if, for example, there is too much sugar or too much salt, that's not healthy for us, so maybe we should choose something else. And many times, foods that are promoted better or that have more attractive packages, they're usually not as healthy compared to non-attractive packages. And same with alcohol and promoting red wine. So that's another very easy thing that we should educate ourselves and try to change in our lives. Even if we talk about eating, even, in order to change all these habits, if we do it as a family or as a group with friends, it's very easy for us to encourage each other. So for example, to have family meals, to eat together, not to be on your phone when you're eating or not to watch the TV when you're eating, to be more aware of what you're eating, and that will reduce actually the size of the meals that we're consuming, and also we will be more aware of what's going inside our body. So it just, again, to say about your question, that there are small things that we can start changing. Instead of, okay, tomorrow I'm starting a diet, I don't have to start a diet tomorrow. But if I will start doing these small changes and become aware of what I need to change in my life habits, that would tremendously help.
Any other questions?
Yes, we have a question from online. This comes from Jeremy. Can you comment on the impact of stress on heart health? Is there any amount of stress that is good for the heart, or is it generally always bad for the heart?
Yeah. So stress is not great is the short answer. So stress can cause can lead to heart disease. That is a newer area of research for sure, but that has, I think, been shown in some studies. And acute stress can actually cause a heart condition called Takotsubo cardiomyopathy, or broken heart syndrome, or stress-induced cardiomyopathy, where that sudden stress causes a surge of adrenaline in the body, and it can actually stun the heart. And patients present just like a heart attack, but when we look at the arteries, they're normal, and then when we look at the heart function, it balloons out. It's called Takotsubo because that's the Japanese word for octopus pot, and that's exactly what it looks like. The heart part of it is ballooning and not working. It's also a condition that occurs more so in females than males, but this is a condition that occurs more in the postmenopausal patient population of generally the average age is 65, 70, so a little bit older. Most of the time it does heal on its own, but when it comes back to stress in general, often I tell my patients, we all have stress in our lives. It's impossible to get away from stress, but it's how you deal with the stress. So if you have a stressful event, are you someone that worries about it constantly, that can't sleep, that starts eating unhealthy, stops exercising? So beyond just having that stress, you're now making other changes to your life that also feed into an unhealthy lifestyle and increase your risk of heart disease independent of that stress. SCAD patients, stress plays a major role in them having more chest pain. Some heart attack patients experience that as well. So things like yoga, meditation, talking to a therapist, understanding how to deal with the stress in a healthy way can help to reduce your risk of future heart problems for sure. And stress overall is just not good for the body, but life is full of stressful events, so really it comes back to how you manage the stress.
That's great. Thanks very much. Any other questions? We have a little bit of time left. We're running down to the half past the hour. Davide?
We have one last question from online. As a woman, if I have chest pain, how can I ensure that my symptoms are properly considered and assessed, given the biases and misinformation that can exist within the medical community?
Yeah, that's a really good question. And I think that communicating clearly. So if you're having chest pain, say you're having chest pain, don't try to minimize or downplay the symptoms. I think both for men and women in this day and age where unfortunately our healthcare system is stretched to the limit. You really have to be your own advocate. Speak up. Get the care and the attention that you need. And sometimes women may not do that because they, again, going back too often, I hear, I don't want to be a bother, right? Something doesn't make sense. Their doctor said something they don't quite understand. They kind of let it slide, but then they think about it later and they're like, oh, did that make sense? So I think really advocating for yourself, seek help in a timely fashion. Write down what your symptoms are so that when you're in front of the care provider, you're not struggling to find the right word or describe it. Often, like Lorrie mentioned earlier, a lot of the time our history taking is the most important tool that we have. It's not it's not the angiogram or this fancy test or that fancy test. It's really listening to the patient and understanding what they're trying to tell us. And people may have different ways to do that depending on what type of clinical situation it is. Sometimes it happens in 5 minutes, sometimes it happens in 20 minutes. So really knowing what the symptoms are, thinking about what they are, recognizing what the red flags are of heart disease, of a heart attack, so that you can say, oh yeah, I had this, oh yeah, I had that. Sometimes writing it down definitely can be helpful. And I think that, again, being your own advocate and not being afraid to get the help that you need is very important in this day and age.
I think before we close, I just want to ask the one question. The internet is a plethora of information. It doesn't matter. You type in Takotsuba cardiomyopathy, SCAD, whatever. Am I having a heart attack or heart attack symptoms? And I just wanted to comment that a little bit of information, it can be quite dangerous. And unless you're speaking to a healthcare professional, your doctor, maybe one of the two of you might comment on that. But it can be quite dangerous, yes, to go on the internet and diagnose yourself.
Yes and no, which is my favorite thing to say to my patients. I think Googling your symptoms can sometimes lead you down a rabbit hole and you end up panicking for hours when you talk to a healthcare provider and they're like, no, that's not quite it. So I think there's a difference between Googling things versus empowering yourself. So if you have symptoms that don't quite make sense, talk to your healthcare provider. Let us help you figure it out. This is what we train for. This is why we're here for you, to help you. But once you have a diagnosis, the internet can be helpful. So for SCAD patients, it is extremely rare. Most of my patients, when they're on the cardiology ward, there's no one else that has it. It can be a very isolating condition. But through the internet, SCAD patients have found each other through the city, through the province, through the world. Peer support is very, very important for conditions, and often women feel they benefit from it more than men do, having that connection. So the internet may be helpful in terms of connecting patients with unique conditions with each other. However, I do tell them, there are Facebook groups and things like that out there for SCAD, but take it with a grain of salt. So like what Lorrie says, it can be a dangerous place. Just because this patient has this symptom or this prognosis, they're told this particular thing, doesn't mean that applies to you. So use the internet to take some information. I often give my SCAD patients a list of good websites for them to go to read about it. Websites that are designed by patients, for patients, by clinicians, good websites to trust, as opposed to more fear-provoking type of websites that, again, just ends up adding more stress and anxiety to the patient. So just like any other tool, technology can be very useful. However, it is important to make sure that it's used in the right way.
Great advice. Thanks very much. So I think we're at time. This was terrific. I want to take the opportunity of not only thank the audience that's here online who joined us this evening. I want to thank our panelists, Dr. Ina Rabinovich-Nikitin, Dr. Shangbo Liu, Dr. Brad Doble, and of course, they say it takes a village. I'd like to express my gratitude to Dr. Annemieke Fehrenhaus, the Vice President of Research International's office. So thank you so much, the University of Manitoba, for inviting us to provide this educational forum this evening. I'm hoping that we'll be invited back because we've got even more information for you down the road. And again, enjoy the evening. I enjoyed this. This was terrific, educational, and we hope to see you again soon. So thanks very much.